Hello and welcome. My name is Liz Calhoun. I am an attending physician with Trinity Health in Philadelphia, Pennsylvania. I am the current chair-elect of the Women in EM section, and I'm here today with a special podcast for you regarding penicillin allergies. I have two special guests today who I will allow to introduce themselves.
Thank you for allowing me to be here. My name is David Kahn. I'm a professor of medicine and pediatrics at the University of Texas Southwestern Medical Center. I'm a past president of the American Academy of Asthma Allergy, Asthma Immunology, and my interest has been in drug allergy, and I was a chair of the work group for our most recent update to the drug allergy practice parameters.
And hello, I'm Michael Bond. I'm currently a professor of emergency medicine at University of Maryland in Baltimore, where I work in a community shop most of my time. And I just have a special interest in myths that have perpetuated throughout medicine, and penicillin allergies and cross-reactivity with other medications tends to be one of those. So happy to join.
I'm very happy to have both of you with us, especially this month, since September 28th is National Penicillin Allergy Day, which is an important day for most because in the emergency department, we see a lot of patients who have penicillin allergies. But in this day and age, it's hard to know who has a true penicillin allergy and who doesn't. And there's so many other antibiotics out there that we can choose from. What is the big deal with patients who state that they have a penicillin allergy?
Our thought process on penicillin allergy has really changed over the years. Even 10 years ago, when someone had penicillin allergy, we just ignored it unless they really needed penicillin and would address it. But in the last decade, we now know that having that penicillin allergy label has significant consequences and morbidity and mortality. So patients who carry this label are more often have antibiotic-associated infections like MRSA, VRE, more likely to get C. difficile. They stay in the hospital longer. They have more post-surgical site infections. There's even increased mortality just from having that penicillin allergy label. And in fact, most people who carry this label really aren't allergic to begin with.
In the emergency department, allergies are by a screen taken at triage, and oftentimes the nature of the allergy or the severity of the allergy isn't even listed. And in these cases, it's important for us to know what the allergy is. Now, there's a new concept I've heard about, penicillin allergy skin testing. That's the old way. Is there a new way that's even better to help us determine if someone is actually allergic to penicillin or not?
Yeah, that's a great question. And in fact, penicillin allergy skin testing was our go-to way of testing for penicillin allergy. But we're moving away from that in most patients and doing what we call now direct challenges, which is essentially giving people amoxicillin at either a full dose or a small dose and then a larger dose to determine if they're tolerant to the penicillin. We find that penicillin skin testing, particularly when we do it in children and low-risk individuals, has too many false positives. And also, it's harder to do in young children. And direct challenges are easy to do, doesn't require any specified training. And this is probably the preferred approach for many patients to remove that label of penicillin allergy, something that we're now calling delabeling.
And what would you consider a positive challenge? What would be a positive result then? Because I agree with Dr. Calhoun that so many people tell me they're allergic and their mother told them they had a rash. So I call those mother allergies, but they can't even tell me like what happened. So what symptoms should I expect if I give them a challenge?
Yeah, so in reality, most people who undergo penicillin challenges have no symptoms at all. In children, the rate of reactions, immediate reactions, is actually less than 1% that you'll actually see during the challenge procedure. And it's a small percentage as well in adults. Most of the things that you actually will see are actually not allergic. And this happens more in adults, especially. And these are more anxiety-related symptoms. So sometimes people will feel itchy without any rash. That's probably the most common thing that we'll see. Some people will say, oh, my throat's feeling a little bit tight, or my tongue feels abnormal. A lot of subjective findings without objective evidence. Things that would indicate a true positive challenge are most commonly a cutaneous rash, usually in the form of urticaria, occasionally angioedema. Anaphylaxis with these challenges, especially when you identify low-risk individuals, is exceedingly rare. One meta-analysis looking at children who were challenged found that only 1 out of 8,000 had symptoms suggestive of anaphylaxis. Anaphylaxis with these challenges, when you select people appropriately, very rare.
So, as a busy emergency physician, I don't always have the time to screen patients for many of the things that I would want to screen them for, let alone for a penicillin allergy. While this sounds really ideal for me, am I one of the best people to perform this challenge, or should this only be performed in the setting of an allergist's office?
So I think that we're talking about a real paradigm shift in terms of where testing should be done. When we think about the approximately 35 million Americans who carry this penicillin allergy label, which we've discussed, most of them aren't allergic. There's only 5,000 allergists out there. There's way more than can be handled by allergists alone. And now that we're using these direct challenge testing modalities, this is something that we firmly believe can be done by non-allergy trained specialists. This can be done by general internists, pediatricians, emergency medicine physicians. The list goes on and on. In our institution, we have pharmacists doing this type of testing. It really doesn't require any special techniques or really specialized training. Just need to have some guidance in terms of what to do. But by all means, this can definitely be done in the emergency room setting. And there have been some studies, particularly in children, who have been delabeled in the emergency room by emergency room providers with no help from allergists whatsoever.
What time frame are we looking at? So I give them their amoxicillin tablet. How long do I have to observe them to say that it was a negative test?
Yeah, great question. There's, I would say, a little bit of debate in terms of how long is long enough. In our guidelines, we suggest anywhere from 30 to 60 minutes is sufficient observation after an oral challenge to say you're not going to have an immediate reaction.
We always talk about great discharge instructions are very protective for emergency medicine. What would be your treatment recommendations for them to go home? Should I send them home with some prednisone or tell them to take Benadryl in case they have a delayed reaction? Or how often are actually there some delayed reactions to this? That am I fearful for nothing?
Yeah, delayed reactions tend to occur a little bit more frequently in children than adults, and the rate of delayed reactions is somewhere around maybe 3 to 4% of children may have a delayed rash after a challenge. And that can occur anywhere from many hours up to even a week later. These reactions are typically very benign, usually a rash that will respond just to antihistamines. So, and they can just take an over-the-counter antihistamine to manage these.
So let's say that I do decide to try this in some of my patients. My residents have already been talking excitedly about this, and I know that they'll be on board with the latest cutting edge ideas in the emergency department. But how do I guide them into screening patients and determine who would be appropriate for a challenge in the emergency department?
Yeah, so I think it depends on whether we're talking about adults or kids. There's a little bit of difference for that. So let me start with children, where we have the most evidence for doing this type of delabeling. Children, basically the only child that you wouldn't do this for would be a child who has a history of anaphylaxis or some other very severe reaction, which would be very uncommon, Stevens-Johnson syndrome or something like that. But any type of rash, no matter when it occurred, even this was, they said, oh, 2 months ago, I took amoxicillin and had a rash, you can still challenge them. And in fact, most of those kids will not be allergic. For adults, it's two features that are the kind of low risk characteristics. One is how long has it been? And we think at least 5 years ago from their reaction would make them low risk. And then the second thing is, was their reaction only rash? Doesn't matter whether it was hives or some other rash, as long as it was a benign rash. Those two characteristics tend to identify adults who are amenable to getting a challenge. Again, we don't want to challenge anybody who has a history of anaphylaxis, any type of severe drug reaction that ends them up in the hospital, drug-induced liver injury, kidney injury, et cetera. But most of these patients, in fact, probably at least 60 to 70% of patients, adult patients, and probably 98% of kids can undergo direct challenges.
Is there any specific script that you would recommend that we would say to patients to encourage them? Because I really do think there's a lot of fear behind this. They live with this for 30, 40 years, and now I'm trying to change their mind. How do you convince them to take the amoxicillin?
Yeah, that's definitely the case for many patients who have lived this for a long time or have been told, like, oh gosh, the next time you get penicillin, it could kill you, things of that nature. So I think number one, explaining why it's important, and because most people and many physicians aren't aware of this morbidity associated with this label. The second thing is giving them the statistics about how uncommon it is for them to still be allergic, and that their outcomes will be much better if we determine that they're not allergic. Once they hear that, and you also say that this can be done in a very safe manner, and we can do it right here in the emergency room, many more people will get on board. For the rare patients who say, I'm not ready, this is not the time or place, etc., then I think referring to do this maybe in an outpatient venue would be appropriate. But I think just that educational piece, which can be done pretty quickly, can get buy-in on most individuals.
One of the things that I recently learned that I started teaching on that I think could help people too, and I tell my residents all the time, a lot of times we'll supplement Bactrim for a UTI when amoxicillin or Keflex might be just as good. But there's population studies out there now showing that the risk of sudden death while taking Bactrim is 7 times higher than people that were on amoxicillin, and maybe thought to be due to hyperkalemia, transient hyperkalemia that we'll never pick up on autopsies. But it just blew my mind that you're 7 times more likely to die by being prescribed Bactrim than amoxicillin. It's just earth-shattering to me.
That's really interesting. As an allergist, we always worry about the more severe delayed reactions that we get from with Bactrim. So I think no matter how you look at it, I think Bactrim is not a preferable agent when we can delabel someone to amoxicillin. Completely agree with you.
Penicillin allergy, in my mind, is a bigger issue because of the fears of cross-reactivity with cephalosporins or the penims. Could you comment on like how fearful we should be? Can I give cephalosporins? Should I not give cephalosporins if they've had an anaphylaxis reaction to penicillin or amoxicillin when they were a kid?
Yeah, excellent question. And this is something that really you'll appreciate because you're interested in myths. But there's a lot of mythology surrounding this. In our recent guidelines, we stratify how to administer cephalosporins to penicillin allergic patients pretty simply based on whether there's an anaphylactic story to penicillin or not. And again, true anaphylaxis to penicillin is exceedingly rare. So if we look at the 99 point whatever percent of patients who are in the emergency room with penicillin allergy that is non-anaphylaxis, they can receive any cephalosporin. First, second, third, fourth, doesn't really matter. They can receive any carbapenem agent, not a problem. For anaphylactic stories to penicillin, the difference here is that we would recommend giving a cephalosporin that has different side chains than the penicillin, which is going to be most of them, but that's really the only stratification there. So for most patients, even those who are anaphylactically sensitive to penicillin, they can receive other cephalosporins safely. And if it's non-anaphylaxis history, they can get any cephalosporin. You don't need to do any testing ahead of time.
I've actually looked into this and wrote an article many years ago, and I could not find any articles that reported on 3rd and 4th generation cephalosporins. So I personally give them with impunity, regardless of any reaction. And then for the listeners, the only one that I really worry about is amoxicillin with cephalexin or cefazolin. So those, the 1st generations have the most likely R chains to be consistent. Some of the myths that I was taught as a student, it was the benzene ring. that was causing all of the issues, and it's not, it's the side chain. But it's amazing how much has changed over the years.
Yeah. Regarding cefazolin, so cefazolin does have a very unique side chain, and in the United States, there's no other beta-lactam that has that same side chain. So this has actually been studied. We're looking at patients who are amoxicillin anaphylactic and receive cefazolin. They all do fine. So cefazolin is actually okay for any type of penicillin allergy. And this is something that many institutions are now trying to work into their electronic health system warning labels and removing that because it's such a unique cephalosporin.
And here I thought our classes in chemistry and organic chemistry were never going to be relevant to our daily practice. But that's a good myth for us to dispel regarding cephalosporin allergies because it always comes up as the very first thing in the EMR, just one other flag for us to process whenever we need to put it in an order. Are there any other myths that center around penicillin allergies that we need to dispel?
I would say some myths are like who can't get tested. Boy, if you're pregnant, can you get tested? You can get direct challenges during pregnancy. Am I too old to get tested? There's no upper limit. Am I too young? There's no lower limit. I think those are some common myths. Another one is my mom has a history of penicillin allergy. Does that make me more likely? Family history does not increase your likelihood. You don't need to do even any test if you can convince the patient to say that doesn't matter, you're not allergic.
I've actually had that told to me. My brother was allergic, so I've been told I can't take it.
Yeah.
So you've definitely made me a believer that this is something I can do and quite easily in my own emergency department. But the next step for me is going to be convincing my bosses that this is something that is appropriate, has been tested, and is safe for me to do in my daily practice. Do you have any resources for myself and for other listeners that we can take to our chairs and our administration to show the safety and the efficacy of penicillin challenges in the ED?
Yeah, thank you for your question. And so our American Academy of Allergy, Asthma Immunology, we received a grant to do some of these projects on penicillin delabeling with the emphasis on non-specialists. And so we developed a resource tools, mainly a series of videos, but also some text as well. And it's very easy to find if you just Google penicillin allergy videos, it takes you right to that. And we have videos addressing why it's important. And your administrator can watch a 2-minute video in terms of why is this important from a health system and what are the barriers to doing this. We also have some patient-facing videos that could be pulled up in the ED and say from an adult perspective and a child perspective, what does this look like? Why is it important to me to do this? And helps with the education. And then for physicians and other staff, bulleted points about how do you do this? How do you break up the amoxicillin if you want to do that? What are the dosing that you do? How do you code it? Very practical information all contained in this website, which we do really hope will be very helpful. And there's even more information for those interested in we call it the Quad AI, 4AI Penicillin Allergy Center that has all this information in it, and anyone can access that.
Do you know if the allergy association's working with any of the EMRs like Epic, Cerner, and the others to make it so the alerts are not so worrisome? Because everybody believes the computer knows all, and it pops up all the time. They have a penicillin allergy. Do you really want to give this Ansaf, the cefazolin? Evidently, the answer should be yes, I do. But better yet, to not even have the alert at all. Is there any work being done on that avenue?
Yeah, it's a great question and an area of frustration for everybody. And we do have members who are working with electronic health records, including Epic, because they tend to be the big game in town, and trying to change a lot of the documentation and a lot of the algorithms, et cetera. Our organization is issuing a position statement really just about the allergy label in the electronic health record to begin with. And probably that's the wrong term to be using in the first place because most of the stuff that's in there is not allergy. And we're acutely aware of this. It's going to take a lot of time and effort to change, but this needs to happen system-wide for sure.
Oh, you could get me on a rant about how seasonal allergies and pollen gets listed under that. how iodine, and nobody could be allergic to iodine, we wouldn't be alive. And then just the fact that half the time it's duplicated. They'll have the same penicillin 4 times and it makes the list look really long. And I just feel like the longer the allergy list is, immediately I get biases against the patient. And I know that it's an implicit bias, but the longer that list is, the more I go in there like with preconceived notions. And sometimes it's just a clerical error on our part, but it definitely changes the care they receive.
Yeah. Interesting your point about the longer the list. So there actually is a little bit of evidence to support your bias, if you will, in that patients who have very long lists, greater than 10 lists, are much less likely to be actually truly allergic. And there's this phenomenon called multiple drug intolerance syndrome, where people just have these subjective reactions to all sorts of different things. And when we end up testing them, we find that they're not allergic. But you're absolutely right. It does impact care, and it's a big problem for these patients and their providers.
That's a good segue. I think Dr. Calhoun could probably agree with me that we see lots of patients that list allergies to certain pain medications, acetaminophen, ibuprofen, naproxen, but they could take acetaminophen as long as it's mixed with oxycodone. Is there any testing that we can do for these to dispel these drug myths, which tend to try to force us into prescribing opiates, which is its own national epidemic?
Absolutely. I'll start with the acetaminophen because that's the least likely thing that's going to cause drug reactions. Certainly in this country, what's interesting is in Europe, they seem to see patients who have reactions to acetaminophen. We rarely, if ever, see that. And there is no skin test or blood test, and how we do it is very similar to the amoxicillin. You can give them a challenge dose and observe them. I think that's very appropriate and can certainly be done in the emergency department, especially if it's going to affect the care acutely. With other NSAIDs, those drugs can indeed cause hypersensitivity reactions. But if we look at taking patients with NSAID hypersensitivity labels, 85% when tested are not allergic. Again, this can also be done in a challenge procedure. The one caveat with other NSAID challenges, ibuprofen, naproxen, there's literature suggesting that when they do have a positive reaction, sometimes it can be delayed. So we had talked about how long we need to observe. The recommendation for observation for NSAID challenges is 2 hours. Maybe that's impractical in the emergency department, but for acetaminophen, I think it doesn't need to be that long.
Thank you.
My pleasure.
To wrap up, Dr. Khan, this has been extremely informative for Dr. Bond and myself. This is going to almost immediately change my practice, and I'm very excited to bring this back to my hospital and try and implement this as soon as I can. Do you have any last pearls of wisdom or pieces of advice for any emergency physician looking to implement a penicillin challenge in their emergency department?
Yeah, that's music to my ears. And I think we started off a lot of this conversation with fear, I think, is the main obstacle. I think there's just a general fear because this is outside of most people's comfort zone about doing this drug testing. But I can tell you, in these low risk individuals, things will turn out well. And the safety of this, there's a long track record. I think it's the right thing to do. And as allergists, we need your help in addressing this epidemic of penicillin allergy, these false labels that are affecting all of our patients.
Thank you. I also appreciate all of your insight into even all the other testing that we could do. But all testing definitely seems like it could be easy and convenient. And unfortunately, sometimes it takes me just 30 minutes just to do my discharge instructions. So observing them for a little bit of time, I don't think will cause significant delays, at least in my shop.
Same here. Dr. Khan and Dr. Bond, thank you both very much for your time today. Thank you for listening to this podcast, and please share this with your colleagues, with your co-residents, with your friends, so we can spread the word about penicillin allergy testing and delabeling in the emergency department to hopefully make all of our lives just a little bit easier and patient care just a little bit better. Thank you.